So he said, I'm Charles Hill, PGY4 out of Del Seaton in Austin, Texas. There you go. No conflicts of interest disclosed, neither did any of my co-investigators. So measures of mood and affecting coping strategies have notable correlations on both quality of life and treatment responses. Literature suggests that psycho-emotional health may correlate better with symptom severity as experienced by the patient than any objective evidence of GERD, and that patients with a previously diagnosed anxiety disorder actually have worse treatment responses. They have less improvement in their patient-reported outcome measures, or PROMs, and less satisfaction postoperatively. So some common PROMs that we've kind of already discussed today. The GERD HRQL score looks at classic symptoms like heartburn, dysphagia, and bloating. And then the Laryngopharyngeal Reflux Symptom Index, or LPR-RSI, focuses on atypical and upper respiratory symptoms like coughing, hoarseness, and choking. And as previously mentioned, higher scores on either of these surveys is correlated with worse symptom severity as experienced by the patient. So the Esophageal Hypervigilance and Anxiety Scale, or the EHAS, is the first validated measure of psycho-emotional health related to GERD. Primarily focuses on anxiety, worry, hypersensitivity, hypervigilance of esophageal symptoms. We recently published a study on 230 patients in our cohort that we were preoperatively evaluating, found that a higher EHAS score was independently associated with worse baseline quality of life and worse symptom severity. And so now we were interested in treatment responses. Can you use this EHAS score as part of a decision-making tool to figure out who's going to respond well from surgery, and does it correlate with the degree of improvement in GERD HRQL or LPR-RSI? So we identified 102 patients that had laparoscopic anti-reflux surgery, LARS, from June 2019 to October 2020, and had at least 6 months of follow-up. We include in our analysis standard patient demographics as well as the results of our preoperative workup, and that's how we decide on basically their level of disease severity. We generally get a swallow study looking at anatomy, pH study to look for evidence of acid reflux, endoscopy to look for esophagitis, and if we have any concerns of dysmotility, we'll get manometry as well. We also included pre- and post-operative PROM scores and the type of surgery that we performed. Our primary outcome that we were interested in is the degree of improvement, specifically in GERD HRQL and LPR-RSI 6 months after surgery. So this histogram represents the distribution of scores, both preoperatively and postoperatively. As you can see, there's statistically significant decrease in all three PROMs. And GERD HRQL dropped from 25 to 2, LPR-RSI from 17 to 3, and the EHAS score from 34 to 15. The degree of improvement in each of these three scores was completely independent of the type of surgery performed or any objective measurement of severity that we found preoperatively. So in patients that meeting surgical criteria for us, everyone responded relatively well with restoration of scores to physiologic normals, and this degree of improvement was independent of the type of surgery or disease severity. Once again, we found that a higher baseline EHAS score was associated with worse symptom severity and quality of life preoperatively, but we also discovered that a higher EHAS score independently was associated with a greater degree of improvement in these scores postoperatively. That's likely explained because worse EHAS early on, worse symptoms early on, but if everybody responds back to normal, then the degree of improvement is greater. So consistent with the literature, psycho-emotional health does correlate better with symptom severity than objective evidence of GERD. In this particular cohort, a higher EHAS score, those patients actually benefited more and not less from surgery, and that is contrary to the current body of literature. Another notable or novel finding for us is that the EHAS score significantly dropped after surgery. Now, the reason this is important is because this was previously assumed to be a static measure and completely independent of any interventions, at least on its in the validating studies. So future studies that we need to look at are how are we going to identify some treatment non-responders? Is this a useful tool to help identify those non-responders? And then also investigating interventions. So do we need cognitive behavioral therapy, coping skills training? What useful interventions for this at-risk population to really improve our delivery of patient-centered care? Appreciate the opportunity to come chat, and any questions?